EM board bombs.
Welcome back to another Ian Board Bob's podcast. It is October 2023. That means it's very soon to boards.
Yeah.
Not to scare everyone listening, as you heard the amazing voice of Dr. Marlena Wasiski-Kuhn. Thanks again for joining us. Pleasure to be here. Dr.
Happy
Hussein.
to join you.
Dr. Hussein will not be joining us. I actually discovered recently Dr. Hussein is on, they do those wine tours out in California.
Yeah.
Yeah, Iltifat's doing a coffee tour. He's doing some type of coffee bean garden tour somewhere. He didn't tell me where. I can't think of too many places in the United States where they grow coffee.
Hawaii?
That's a great point. I'm sorry. Continental
Probably. United
States, I should have said.
Yeah.
Hawaii is a very good point. Anyway, now I feel like an idiot. So this is Ian Board Bombs. I'm a huge geography nerd. This is Ian Board Bombs. And here we give you amazing content. You come for the stems, stay for the content. For less than 20 minutes, we tell you what you need to know for the boards and for hashtag EMLife. So let's dive right into it. We got an interesting episode here. We have a personal testimonies today from Dr. Wasiski-Kuhn. I mean, this is pretty amazing. How often do you get that on a podcast?
Yeah.
Too often, but this time it's going to be legit. We got a 49-year-old female arriving from home with a concern for a rash. She's tachycardic on arrival and febrile. You examine her in triage, and she has purpura noted on her legs and arms. She also has ulcers in her mouth, and her eyes are quite red. She is tearful, and you comfort the patient saying that you plan to figure out what's going on. She responds saying, "It's not that. I can't believe TikTok is starting a paid subscription of free ads." She's working hard on monetizing her TikTok and has read about 4 online guides. She says she's currently designing her own ads too. You really don't have any words to say in response to this. So you tell her that you'll go put some orders in the computer. She has a fever of 101. She's tachycardic in the 110s. She states she has been treated for some type of skin infection last week. She was put on an antibiotic she cannot remember the name of, but says it starts with a B. She also says the antibiotic wasn't really working that well and started taking essential oil peppermint she's used in her diffuser. She states that has helped. What is the most common initial symptom in this condition? Choice A, fever. Choice B, purulent conjunctivitis. Choice C, mouth ulcers. Choice D, truncal erythema and raised macules. Marlena, what's the correct answer? Drum roll.
The most common initial symptom in this condition is fever.
Fever. We need to cue the Christopher Nolan music. We're talking about Stevens-Johnson syndrome and toxic epidermal necrolysis. If Iltifat were here, he could not pronounce necrolysis.
Oh, for sure.
He cannot pronounce it. It's insane. Anyway, we love him. We love him to death. We love Iltifat. But he can't pronounce necrolysis.
Which is the real reason he's not here today.
Which, yeah, he's like...
He heard what it was about, and he was like, You know what I have to do? A coffee tour.
Wait till we get to some of the drug names here in a minute. This is a group of severe mucocutaneous reactions. They're most commonly triggered by meds, and they're defined as these really extensive, full-thickness necrosis and detachment. Never a good word when you associate the skin with detachment. Mm-mm. Detachment of the epidermis and mucous membranes. It's weird. It's pathophysiologically autoimmune, not fully understood, could very well be alien. We're
Most
not
likely.
sure. Remains undecided. I'm sure there's a Twitter or subreddit page talking about this. SJS and TEN are considered a disease continuum. And here's the deal here. They're distinguished by this percentage of body surface affected by blisters and erosions. So SJS is less than 10% of the body surface. TEN is greater than 30%. And then there's this overlap between 10 to 30%. So aka every single note you'll ever see is probably going to be from a dermatologist, SJS versus TEN, because no one really ever knows unless you really go and you measure the entire body surface area. So,
but they'll definitely ask you questions about that on
for sure.
exams. But it'll
Absolutely.
tell you, like, it involves 50% of the patient's body.
50%. Yeah.
That's terrible.
That's awful. Hey, before we talk about this nightmare, why don't you tell us about EM rapid bombs? And then you're going to get to your testimonial.
Yeah. So, well, my first testimonial is about EM Rapid Bombs and how much I love it. EM Rapid Bombs is our subscription podcast. You get
Mhm.
multiple short, focused episodes a week to cover one really specific topic. Like, there's a couple different episodes on SJS 10, and they are very focused. I personally listen to them in the morning and evening when I brush my teeth for spaced repetition.
A clean mouth and a clean brain.
Yep. I have my boards in 1 year, so I'm getting ready. A different podcast every day. You can sign up today.
Sign up right now when you're listening to
Right
us.
now.
Just get it over with. We have a following in Hong Kong right now. Ireland, I saw recently. Dublin. We got people listening over the world.
I like Hong Kong because then I can like realistically say I'm big in Asia.
You are the hit sensation. You're gonna be like the NBA players when you go to China or something. They'll be flocking towards you, like, "Oh my gosh, it's Marlena."
Except
Anyway,
that I'm like 5'4".
Hey, that is true. Hey, how common is this nightmare?
So it's not common. It's pretty rare. Like max 7 million people a year. More common in older adults. The median age is 50. But my real testimonial here is that I personally had SJS when I was 22. So don't lock yourself into like old populations because I was a 22-year-old woman.
You've had it?
Yeah, I did.
I'm just learning this right now.
Yeah, Dr. Briggs did not know that until we were doing this podcast.
Why don't you put that on your resume? I mean, I feel like that's something you should have like honed in on in your med school or residency interviews.
My personal experience. It was
that's a personal
terrible.
statement, really. Let's be honest. Someone would have mentioned that by now in this day and age.
Yeah.
When I had Stevens-Johnson syndrome.
So it's funny because I had it in response to Bactrim, which is why I now have a secret hatred to Bactrim.
No, it's an awful drug.
Yeah, and I had just started dating my now husband, and I had
glad it worked out.
I had the So that's why this is funny.
He saw you at your worst.
He did. Well, actually, so I had started having like red eyes and like sores on my mouth, and I was like, "Oh my God, what's going on?" And then figured out what's going on. I messaged him and was like, "Hey, I have to be admitted to the hospital. I have this thing called Stevens-Johnson." And then I immediately was like, "Don't Google it. Don't look it up. The pictures are bad. Don't look at it." And he had already looked it up, and he goes, "Oh God, well, guess I'll like see you when you get out, maybe." I was like, "Yeah,
good luck.
Don't come see me." So
he's like, "Well, that was fun while it lasted."
Yeah, I'm sure he was thinking like, this is an easy way to just break it off. I don't want to see her face. Ugh.
He probably started his own subreddit page. He's like, my, girlfriend of 5 dates now has Stevens-Johnson. Do I call it off or not?
And then everyone Googles it and they're like, get out while you can. Yeah. Luckily, like it didn't get too terrible and I was only in the hospital for a few days, but it was not a fun time. And he did not visit me.
That's probably a good idea.
Yeah.
Didn't want to see you at your worst.
That's my story. But
anyway,
so
tell us what you felt. Let's go through the symptoms. So yeah, it's exceptionally rare in children, right? Yeah. You're going to see this in adults never. Only. Yeah.
Yeah. It when it is in kids, it's more common to be caused by infections than meds, probably because kids don't take a lot of meds. It's like mycoplasma and HSV.
Of course.
And then there's some patients that are more likely to get it, those with immunocompromised systems.
Like HIV, heme malignancies. Heme malignancies are such a risk for everything. It's insane.
Yeah.
Such a risk compared to solid tumors. And then, connective tissue disorders, whatever. They're all at higher risk of getting SJS. So what's the mortality rate?
It's no joke. Like, it's pretty high, 30%. It's obviously much worse in those with TEN than SJS. And the patients die of like sepsis, ARDS, DIC, multi-organ failure, all the terrible things.
Horrible things.
Yeah. Since you're really good at pronouncing things, I thought I'd let you go through the meds that are often causative.
I'm a professional pronouncer. Hope you're listening, Iltifat. So drugs are the obvious most common offenders here because it's in adults. And essentially any drug can cause it, as we always say, but here are the top worst ones, the ones in the test question or the ones, they can do this, they'll give the whole prompt of what's happening to this patient. And then they'll say, hey, out of all these, meds we just mentioned, which one here is actually the one that's probably causing this problem? They'll do that for sure. So lamotrigine, the seizure medication, phenobarbital, carbamazepine. So really any anti-epileptic drug. This is like the calling card of any anti-epileptic drug. It's the most classic side effect from these, lamotrigine being the worst. Sulfa agents like Bactrim or sulfasalazine, allopurinol, NSAIDs even. Funny enough, I didn't mention penicillin. Penicillin is actually not that common of a risk here, which is shocking. So on the test question, don't pick penicillin. Do not pick penicillin. It's not the answer. The sulfa agents and the anti-epileptic agents essentially are your two worst offenders. Let's just rope that in here. So typically the causative agents administered like 4 days or so to 4 weeks before the onset of symptoms because it's a type 4 hypersensitivity reaction. It's kind of like poison ivy, but if poison ivy could kill you, it's like poison ivy. Hey, why don't you go over the presentation and we'll talk about some really nerdy stuff. And I think the best way to do this is we go over a differential. Can you imagine? I'm just thinking on shift. If you had like a med student and it's like, the med student's probably ready for like, hey, what's the differential for chest pain? Hey, what's the differential for abdominal pain? What's your workup? Could you please give us the differential for painful coalescing erythematous macules with sloughing? Go now, please.
And then there's that one med student that just immediately rattles them all off, and you're like, wow, you're probably right. I don't know.
Yeah. What was your step one score? Yeah.
In reality, if you think about it, when I say all these things, it's going to sound familiar. So that, erythema multiforme, generalized exanthemus pustulosis, cutaneous vasculitis, fixed drug eruptions, pemphigus, both vulgaris and bullous, Kawasaki disease, and staph scalded skin in kids specifically. Mm-hmm. But cues that are going to help you are the description of the rash and presentation of mucosal involvement is going to help you narrow it down. You may note that I didn't say dress, and that's because it never has skin sloughing.
That's a really big point. Keep that in mind because everyone throws the word dress around here. At least in my shop, some people say, oh, it's dress. Oh, yeah, that's like dress. But that's a really big point. No skin sloughing for dress. It's not that severe in terms of Stevens-Johnson or 10. Anyway, keep going.
Right. So there's, the question that we asked was about the initial presenting symptom back in the introduction. And there's almost always a flu-like prodrome, a fever is usually greater than 101. They'll have other symptoms that'll precede the lesions, like malaise. And then lesions are going to form a little bit after the fever, and then mucous membranes are going to be involved, especially the oral ones. Those are over 90% of patients are going to have oral lesions. And there's usually at least 2 distinct sites for mucosal involvement: ocular, oral, genital. Just remember that boards are not going to present you a patient with SJS-10 that don't have mucosal involvement. And they're going to be very painful erosions.
What about the skin lesions?
Yeah, the cutaneous lesions, the skin lesions. So usually they're pretty ill-defined. They're coalescing. You can remember them to be typically erythematous macules with purpura. They're very tender to the touch, often with pain out of proportion. So treat the pain of these patients seriously. Speaking from experience, it is so painful. Like, give them pain meds. The palms and soles are not involved. I know that's like a question that we always ask patients. And the lesions are typically going to start on the face and upper chest and move caudally. As the disease worsens, the lesions will continue to spread, and they're going to form like vesicles and confluent bulla.
Yeah. So speaking of palms and soles, I have a mnemonic that helps remind me the 4 big conditions that cause rash on the palms and soles. Are you excited to hear about it?
Yeah.
It's pneumonic rash.
I like that. Makes
R-A-S-H. Well, it doesn't really work out that way. You're going to laugh at me in a second. R is Rocky Mountain spotted fever. A is Kawasaki's.
Okay.
Sorry about that. S is syphilis. And H is hand-foot mouth disease.
Okay, I'll accept it.
Those are the big ones. I mean, there's some others by out there, but those are the big 4.
Yeah.
That's all I got. Hey,
Well, good.
speaking of named things, this patient's going to have a positive Nikolsky sign. This is the one if you gently apply pressure to the skin, the area of skin sloughing will continue. Sounds horrifying, because it
Yeah.
is. Even though we talk about this and it's great diagnostic skills here, really seriously try to avoid doing this. One, just not nice. It's gonna be very
Yeah,
painful.
why?
Two, it avoids shearing the skin, breaking bullae. It exposes the skin, leaking fluid, protein, risk of hypothermia, risk of infection. So just don't do that. I mean, I understand that you have to diagnose things, but that's not really going to add anything other than just a board exam question here. What they're trying to tell you.
Yeah,
Back
it's
to
not the thing to like call the med students in the room and be like, everyone, try this Nikolsky maneuver on this patient.
Yeah.
Like 10 different
everyone
people.
touch the patient's skin.
Don't do that.
Back to the oral and mucus stuff, because that's so critical here. So far, what I'm getting from you, Marlena, is fever, skin, and mucus findings, severe rash after a drug. That's it. And that's Stevens-Johnson T in a nutshell. Severe conjunctivitis is seen in 80% of patients. So again, we're really honing in on that mucous membrane stuff. You may see some corneal ulceration, purulent discharge. This is a big, big deal. On every article here about taking care of patients with SJS in the ICU, almost always involves ophthalmology being consulted for corneal ulcer management. These are very common in patients. Very scary stuff. You can also get uveitis, and you can even get GU stuff. So you may be calling GYN because of urethritis. Now, as an ED doctor, are you calling those people? Probably not. Hopefully, you can get this patient transferred or up to the ICU as soon as possible, where all that care there is going to be critical care. But you just have to be aware of all this. One, if you're an ICU doctor. Two, if you're rotating the ICU, that this is the intensive broad spectrum care that they're getting. Now, this may sound like a broken record, but labs are not helpful.
No.
Everything we talk about in this podcast, labs are not. Eventually, we'll cover like iron deficiency anemia, and we'll say, get a hemoglobin.
Labs actually will tell
labs
you
are the
something,
diagnosis.
but not here.
Not here. As many as 10% of patients will have thrombocytopenia. Yes, they can develop DIC and other, scary sequelae of laboratory abnormalities from the massive, fluid shifts that are happening from this basically a severe burn, full thickness burns. But remember, this is a clinical diagnosis at first. None of the labs are going to help you. I always laugh when certain people get labs for like cellulitis, and I'm like, I don't think it's going to help you at all. What are you going to look?
No.
What are you going to look for? Leukocytosis? I mean, anyway. So sorry to disappoint the off-service intern here who's excited, but none of them are really going to be doing skin biopsies either. Although I will say I did do a skin biopsy one time that deserves a story. If you want to stick around, Ian Borbaum's audience, when I was a resident, I had a patient that had Stevens-Johnson ED, and the gratitude of working at a level 1 academic centers, you can consult derm at 2 a.m. And this poor derm resident, I think it was the first time she's ever been woken up at 2 a.m. God bless her.
For sure.
Because I remember I called her and I had to repeat the story 3 times because she kept falling asleep. And then and she said, okay, I'm coming in. Okay, I'll come in to do the biopsy, whatever, sounds reasonable. It was a very obvious case of Stevens-Johnson. And I guess my attending wanted the biopsy now, I don't know, at 2 a.m., whatever. So she came in, did the biopsy, and then she left, went home. Well, the problem was she took the biopsy home with her.
Oh, no.
She was so tired. She just slept, walked out of there. And so the nurse, she left her equipment at bedside, and the nurse is like, she never sent the biopsy. I'm like, well, I could call her again. She'll come back in, or I could just do it myself. And I YouTubed it, and I did it myself.
Oh my gosh.
And it was Stevens-Johnson. So I'm 1 for 1 for skin biopsies.
Wow. I mean, that's huge.
Mm-hmm. Huge stuff.
I hope I never do a skin biopsy.
It was pretty easy. It was just a punch biopsy. It was not that simple. It was not that complicated here. Hey, let's get into the treatment here and wrap this up.
Yeah. So the first step in all serious drug reactions, don't forget this. It's a trick. If it's a question, stop the offending agent. Don't forget to do that. Stop it. If there's more than one possible causative agent, just stop all of them. Add the drug to the patient's allergy list because they should not take it again.
So what's your job in the ED? I feel like we're covering a lot of critical care. Let's just simplify it here for the average emergency doctor.
Yeah. So your job is to not miss this. Make a clinical diagnosis.
Along with every other emerging condition.
Yeah, as we say. I feel we say this all the time, but you can't miss this. There's high mortality. Yeah. But really, you don't have to work it up. You just have to look at it and recognize what it is by the way they look in the history. Fever, skin and mucous membrane findings. Start thinking about SJN, and for God's sake, do not send them home with another antibiotic and derm outpatient follow-up.
Oh my
Don't
God.
put them on Bactrim and send them home, please.
Yeah. I think we should just increase your Bactrim dose. That'll cover it.
Oh, God.
So patients with this disease all require transfer to a regional center that feels comfortable with burn management. So typically level 1 trauma centers or just some type of level 1 burn center. The Lund-Browder chart, which we typically use for our burn patients, this is good for assessing the degree of burns. You got to treat these patients like burn patients. Supportive care, wound care, fluid electrolyte management, pain control, infection prevention, all that is the mainstays in the ICU. And because it's limited to the superficial layers of the skin, don't do the Parkland formula. First of all, you shouldn't ever do the Parkland formula like ever again. The Parkland formula is so outdated now. It's such a joke. Boards, I think, are getting less and less away from testing that. Anyway, don't ever do that. You could do some type of your own resuscitation of like a thermal burn patient. Some sources recommend starting 2 mils per kg times the percent affected area of TBSA. That's the new kind of standard formula they're using in a lot of patients. Just remember, to consult people as needed here. When these patients hit the door, they're going to be sick. You call the ICU. If there's prolonged boarding and you're stuck in a position kind of where you're taking care of the patient here, yes, go ahead and initiate consults to derm, initiate consults to optho, GYN. These are sick people. Hopefully you're not in that situation. I hate it if you are. If the patient shows signs of infection other than a fever, which is very common, right, because of this inflammatory condition, go ahead and start IV broad spectrum antibiotics. I mean, it's stupid not to. We've talked about TTP a few weeks ago where you do IV antibiotics because it's just impossible to know. We're dealing with so many unknowns in the ED. That's not going to fix their condition. Prophylactic antibiotics don't do anything. But yes, you don't know if there's underlying infection or not. They're super sick. Of course, they're going to get IV antibiotics. Now, you may have taken care of these patients before, or you may have heard Marlena's testimony on Reddit. And people have talked about getting steroids, getting IVIG, getting immunomodulators. No one really knows how to treat this thing. Sometimes people think steroids make it worse. So no one really knows what to do with these patients. It doesn't matter. Don't start any of that stuff. Whatever you do, don't start IV steroids. That is not the right answer here. No. Don't do that. Let someone else make the decision. Supportive care is clearly what the only indication is for these patients here. And recovery time, well, you can ask Marlena, or the book says about a week, usually skin sloughing stops. It usually takes up for 3 weeks after that for re-epithelialization if they survive.
Keyword, they're going to be in the hospital.
Dun, dun,
they're
dun.
going to be in the hospital. Yeah.
Dun, dun, dun. All right, let's wrap it up. Rapid Bombs. We never really said where you can get the Rapid Bombs podcast. You can go to our website at emborbombs.com. Don't forget the www. I don't think you need that anymore, though. But
http://
No, we're HTTP secure. HTTPS. Ooh. Thank you very much. This is a modern, legitimate business website. Anyway, we'll see you next time. Thanks for listening.
Adios.